For those who weren't on a few minutes ago, I'm sorry that I'm a little red and sweaty. I went for a run right before this call. But I work for NACCHO. We're the National Association of County and City Health Officials. So we're the membership organization for local health departments. We work all across the US. And we really have started to build out our portfolio of syndemic work. I'm within our HIV, STI, hepatitis, and harm reduction team. And we sort of define nationally the syndemic as inclusive of HIV, STI, hepatitis, and then substance use related harms. So whether that's overdose wounds or those infectious diseases I've already mentioned. But really recognize that the nature of the syndemic is very local to every jurisdiction. And so have been trying to do more work to help health departments figure out, what does a syndemic approach look like within their community. I think that's one of the biggest things that really defines our work is there's a lot of solutions that, nationally make a lot of sense, but the work does, really need to be tailored specifically to each community and jurisdiction. Um, I think, the first thing I will say is that one of my colleagues, Julie Carr, who some of you might know, is much more knowledgeable about the opioid settlement process and opportunities than I am. She just started her parental leave a couple days ago, so I'm currently getting caught up. Um, but I think it's something that what we see in actually the harm reduction space is sometimes health departments and local health officials are, amazing advocates for this work and, advocates, but also providers, champions. They support other organizations. They do the work themselves. And sometimes there's often a need for local health departments and local health officials to better understand harm reduction. And so the role that we really see health departments playing definitely varies within different jurisdictions based on who's best suited to do that work. Tony, was there a specific question or an aspect of our work that you wanted me to talk more about?
I really want you to talk about kind of what is NACCHO doing, especially in response to opioid settlements? Like, what are you looking at? What are you tracking? Because
Yeah,
counties are playing a pivotal role
yeah,
in how these dollars are being led.
yeah. I think what we've been trying to do so far is there's definitely been just like a level of trying to navigate it all. I think Community Education Group has done a really great job for the Appalachian region, and there's other parts of the country where there's not, an equivalent organization that has a good handle on what the process looks like and how to influence it within every jurisdiction. And so a big part of what we're trying to do is understanding, um, you know, it varies so much across the country, but where are the levers of influence? Who are the decision makers, officially and informally, and helping health departments navigate, how they can figure out in their jurisdiction the best way to influence those funds. And then, of course, working with the right community partners to make sure those are used in the best possible way. But I do think going back to what you were saying earlier about, SAMHSA, there's also this piece at the national and federal level where there's a need to understand what is being achieved with these and consequently how existing federal funding should shift around that. But of course, we always have to be really, really careful when talking about that. Often if you say, well, this is being done, then our federal partners or especially Congress might not think that the existing funding is necessary. So I think, we're trying to monitor that and get a better hold on that. But I think even the people we talk to within the federal agencies, a lot of them, it's still a bit of a black box to them in terms of what sort of the national landscape looks like for how they're being used.
Yeah, I mean, I think that that's one of the things that we certainly have found is that many times when we have a conversation with federal partners, they're like, we don't know what our role can be because these dollars or this was done by court decree and we don't really have a role. And I kind of disagree that they don't have a role, right? I mean, they may not have a role in oversight, but I think that there's a role in knowing, right? You need to know, for example, County X got, this number of dollars, and you don't want SAMHSA to then come in and say, oh, we're going to fund 15 programs to do the exact same thing, when maybe the 15 programs could have gone to fund something else. Yeah. And so I think that that's one of the things is that, the Appalachia region's 423 counties also 40% of those counties buttress up on more than one state. So figuring out how is it that the federal government allows for RFPs or notices of funding opportunity to allow organizations to go across multiple states. Because as I said earlier, one of our missions is to bring resources, opportunity, and attention to the Appalachia region. That's not just money. And I always have to tell them that's not just money in the CEG's pocket, but it's to make sure that we can get more resources into the region. And that's why I like to do calls like this. Yeah, I wish Dr. Oil was here because then, but we're trying to make it do what it do in the meantime. But I think that we want to also be able to bring federal partners, partners like Dr. Lloyd and others here, so that folks know that they can have access. Michael, I'm coming to you next, and you're like, why is she talking to me? Michael, I'm talking to you because you're the data guy, right? So you are can you tell the people where you are in is Eastern Tennessee? I'm going to get it wrong, right? But and what you guys are working on, because I think it's a pretty phenomenal piece of work.
Yeah, so yeah, I'm at East Tennessee State University where I direct our Center for Rural Health Research. I used to work at NACCHO, so I've got a real long history of doing public health systems work as well. We work at the intersection of rural health and public health, and a lot of our work has focused on opioid misuse and overdose mortality in particular, given where we're located. So we've developed a lot of mapping tools focused on overdose data as well as recovery data. We like to think about recovery ecosystems, what supports are necessary to have in place to support people in their active recovery. So we have a tool, it's rei.norc.org, where you can learn about both the recovery data and the overdose data.
Hey, Michael, can you drop that? I'm sorry to interrupt you, brother.
I will do
that. Can
you
drop that down in the chat so folks can capture
it?
Yeah,
I will do that, absolutely. But yeah, so we have these tools, which I think are really good starting points for the community planning. They're very high level. They're reliant on national data. So we encourage people to drill down and supplement that with state and local data. We're not able to do that for every county in the country just because of the scope and scale. But I do think they're useful in terms of being a starting point. And then we have done a fair amount of work for the Centers for Disease Control and Prevention and the Health Resources and Services Administration, focused on overdose in general, but also focused on the roles that health departments play in addressing the opioid crisis.
And so if I came to you right now, Michael, and I said, what are the biggest challenges that we're looking at ahead? And what would you tell me your data set is showing?
So, what I tell you about is some work that we've done in Eastern Kentucky, which is kind of the flip side of what you're describing. So in Eastern Kentucky, we have observed across many of the counties that they have had some of the steepest declines in overdose mortality of any counties in the entire United States. When we did this work, 8 of the 10 counties with the steepest decline in overdose mortality in the entire United States were Eastern Kentucky, 14 of the top 20. So what I would tell you is what has worked in Eastern Kentucky is expansion of Medicaid to make sure that everybody has on-demand access to treatment when they want it. They don't get put on waiting lists. They get directly put into treatment. Harm reduction, I see somebody making that statement. Kentucky has the largest number of harm reduction sites of any state in the nation. That's important for disease prevention, but it's just as important for making those connections to help people seek recovery and find treatment and recovery when they're ready. They also have had a lot of political will, so these have not been politicized issues. This is a bipartisan effort across Kentucky. They've engaged in primary prevention and school programs to prevent a next generation. It's been this all hands on deck, and probably the other one that's really notable is that they've engaged their criminal justice system, the police and the court system, so that people are more likely to be referred into treatment than to be put in jail. So I think it's all of those things together that really has worked to reduce those rates in Eastern Kentucky. And, I'm sitting across the border in Tennessee and I'm jealous of Kentucky, and all of us should be jealous of Kentucky because they've had such great success. Not that there isn't more work that needs to be done. Their rates are still higher than the national average. Too soon to spike the football, but they're having really good success. Success needs to be celebrated, and they need to double down on the efforts that they've done, and we all need to follow and see them as a model.
Kat and I were just at a meeting, and actually Kentucky came up, and so I'm gonna throw the skunk in the room, and the way I'm gonna throw the skunk in the room is that I'm gonna ask you this question: if Kentucky were building their system today, would that system be able to be as effective?
So I think so, and here's why I think so. Um, During COVID, everyone's overdose mortality rates went sideways, and it was because of lack of continuity of care and isolation and economic challenges that resulted from COVID. So everyone saw these huge spikes in overdose mortality, including the people of Eastern Kentucky. Yet, following COVID, or as we've started to move into the COVID recovery phase, in 2022, Kentucky was one of only 8 states to have a decline in overdose mortality, and they continued that decline in 2023, which is the latest data that we have. And again, not a lot of states have done that, but Kentucky has. So what that tells me is that the systems and structures that were put in place in Kentucky prior to COVID, when we did our initial study, still have worked and have allowed them to recover faster than other states.
So let's talk about political will. Okay, let's talk about the impact of political will. Do we believe that in 2024, the same political will that then Governor Pence put into place in response? Because and again, for those of you that don't know, I try to treat these calls like we're having coffee and y'all aren't here, and so if Governor Pence were having to do a response to what was the Hep C outbreak amongst people who use drugs in Kentucky today, do you think that there would be the political will to open up the SSPs to have the response across the state that we've got today?
I don't know. It was the first Governor Beshear that expanded Medicaid in Kentucky, and the current Governor Beshear has really doubled down on a lot of those efforts. I think if there were an HIV or hepatitis C outbreak of the scale that we saw in Indiana, I think if we saw that in Kentucky, they would be much more primed to have an adequate response. And I think, again, they have those systems and structures. They have that harm reduction network in place where Indiana really didn't. So I think they would have been in a much better position. I do think that some of that really is a demonstration of political will. Both the first and the current Governor Beshear were both Democrats, or are both Democrats. And that certainly, I think, helped them move towards Medicaid expansion. But Hal Rogers is really the champion in Eastern Kentucky, and he's a Republican. So, a lot of these efforts are, I do believe, bipartisan. And actually, here in Tennessee, our new health commissioner was a former Republican senator in Kentucky. And while he was a Republican senator in Kentucky, he was the champion for the harm reduction programs in Kentucky. So I do think there are some bipartisan opportunities. What I do think happened in Kentucky is that the rates got so high that it was hard to point fingers at other people and say it's somebody else's problem. Everybody was affected, so it allowed everybody to come together. And that's a hard thing to achieve without hitting rock bottom. And I think that in many ways, that's what happened in Kentucky as well.
Right. Right. Danny, Clausen, you had your hand up at the very beginning of this. Do you want to pop on?
Yeah, it was just a question when you were talking about the 1115 waivers and the work that you're doing on that. I went to that lecture. I've already started talking to people in Virginia to see what we can do to get that here. And my question was is there I've done a lot of work in politics, and so oftentimes there's a department of whatever at Harvard or a consortium in this random state. Like, is there any experts or institutions that are available to kind of talk to people about how they got it done in their state, or look at the model legislation? Just wanted to see if there were any like resources around building that in your own state.
Lee, do you want to jump on and talk about that?
Yeah, I'm happy to. Danny, I may not be the best person to talk about, what individual states, like in terms of implementation looks like, but I can speak to the advocacy work that CEG has been doing, and honestly, many of you on this phone call have been involved with this. It's been really important to us to take the opportunity during this final year of the current administration to make sure that we are doing everything we can to pull the advocacy levers to make sure that good policy that's in works at the state and national level, can be effectively implemented, right? Like within the next 6 months. So many of you have probably seen and signed on to some letters we did on the urgent need to approve the pending 1115 Medicaid waivers that are related to allowing folks in incarceration settings to get onto Medicaid before they leave. Again, I saw Kat drop some stuff in the chat. We know that if someone walks out of an incarceration setting with a Medicaid card in their hand, they are much more likely to be able to successfully translate back into society, right? Stay on their medication for opioid use disorder, access a whole bunch of other services. I'll go ahead and drop in the chat once I finish this, but we did send a community sign-on letter that over 90 organizations signed on to. National Harm Reduction Coalition signed on to that. Drug Policy Alliance signed on to that. See some folks from those organizations on the call today. To CMS saying it is really urgent that you approve these waivers. And we actually think a lot of that advocacy work is working. There's a pretty standard process they are going through. I don't think anyone thinks CMS is proactively being slow on this process, but we want them to meet the urgency of the moment. Several months ago, they approved a handful of initial applications, and in the month of July, approved in 2 batches, 5 applications, and then an additional 2, but there's still about a dozen that are pending. So we're going to continue to do advocacy work on this in partnership with a lot of y'all. If anyone is interested in getting more engaged or take a deeper dive into that work with us, I'll drop my email in the chat. Happy to chat with folks about it. And I think, what is a really powerful tool that states have at their disposal, and more urgent work needs to be done.
Do you have, could you send out the sample legislation or a sample policy? We're still in the space where like I need to find a state rep to like sponsor a application. And so if you have a sample application or anything that I could use to start shopping around, that would be super helpful. And if anybody on the call has experience, and I have experience in advocating against an 1115 waiver in Georgia they were trying to close the healthcare marketplace in Georgia a few years ago, but I don't have any experience with like building an 1115 waiver and getting it through. So
perfect.
Thanks.
We'll get all that to you. And I think that's a part of the reason we like to do these calls, is to be able to have these kind of conversations. What are the tools that you might have that we don't? Kat, are you guys doing any work around the 1115 waiver? Are you in there at all? I know that you guys have supported us on a couple of other issues. And I think, did you guys sign on? I don't remember if you signed on to the letter or not. I think you did.
I'm not sure if we signed on to that specific waiver. We're not doing a ton around it right now, just sort of monitoring it. We're definitely supportive. But for now, letting some of our partners who are more experts in the topic. So I've been trying to stay aware of it. But yeah, I dropped a resource in the chat. NVHR had a wonderful webinar on it recently with some speakers from, I want to say 2 different states that have successfully, maybe Washington and California. And both of those speakers were really, willing to talk to people in other states interested in pursuing this. So I would say definitely check out that webinar, the recording and slides are there. And some of the speakers on that might be good people to reach out to as well.
Okay.
And
perfect.
if there's not information in the slide deck, you know, NACCHO, we're connected to NVHR. So you could, Danny, you obviously have my email address. You could reach out to me and I can help get you connected.
Perfect.
Yeah,
Thank
I'm
you.
actually good friends with Adrian. So, and
Perfect.
Dan, reach right out to them.
All right, perfect. Thanks. And I mean, and so now this is the part of the show where it gets really tricky, because I am actually I'm gonna Jim Hall. Who are you? You're just such a distinguished looking gentleman. I want to know who you are. Yeah, you. Yeah, you.
Hi,
Hi.
I'm a retired epidemiologist,
Mhm.
and I'm on a scientific advisory group for the National Drug Early Warning System, and I reside in the Eastern Panhandle of West Virginia.
Oh, okay. Well, I mean, I'm so glad. I'm so glad you're here. And I honestly, this isn't. And some people think sometimes I do put a plant in the audience, but this is not a plant in the audience. Jim, can you tell me how you ended up here and what you do now that you're retired? Did you say retired,
Primarily,
right?
yes, I am. I just turned 80.
Uh-oh. All right. If I can look that good at 80, I'll be happy for it.
Well, the camera helps, but um, I'm working with local coalitions here in the region of West Virginia and our tri-state coalition, but primarily with the National Drug Early Warning System, or NDUS, out of the University of Florida. Most of my work over the last 40 years was in Florida, but involved national projects and tracking primarily emerging drug issues.
Can you
For
maybe
instance,
can you tell us maybe what you're this national drug warning system? Because I see a few people going, what is that? Can you tell us what it is?
yes, it's a program out of NIDA, National Institute on Drug Abuse, that's based at the University of Florida, and monitors uh, numerous sources of what are emerging issues, from internet activity to forensic labs to harm reduction programs, and ndues.org is the home address. And they publish a weekly newsletter that tells what are the latest new trends that we're seeing, both by research summaries and other data sources. And that's a free subscription. Simply go to ndues.org and ndews.org. And on the home page, you can subscribe free to that weekly newsletter, which gives what are kind of the latest new exotic issues, and tracking particularly after fentanyl, other synthetic opioids, and as well, particularly looking at veterinary medication misuse. While we all know about xylazine, there's a whole new patch of other potential veterinary medications that are easily available online or by wholesale dealers who may be mimicking the patterns that we've seen with xylazine. So it's what are the latest trends. Now, some good bit of news that we have seen nationally, um, modest declines in fentanyl overdose deaths um, in the from 1 year ago, from September 2023 through February of 2024. That's the latest national trends. And we're seeing that also in West Virginia, I know, and probably in most of the other Appalachian areas. Modest declines now. We're talking like 1% decline, but at least it stopped going up and stopped increasing. Probably much of that's to do with harm reduction programs and naloxone distribution.
Right. And so you and so tell me about the project that you're working with. You said in the Eastern Panhandle. So is that with Dr. Reedy and that group over there, or you something else? Tell me what you're doing over there.
Yes, Dr. Reedy with the Jefferson
He
Berkeley
used
Alliance.
he and I used to go together, but we broke up. I don't know. He never calls me anymore.
Well, I'll get on his case.
Okay, do that.
Uh, but yes, with the Jefferson Berkeley Alliance, the Martinsburg Initiative, and a group now that we refer to as the Tri-State Coalition, looking at Maryland, West Virginia, and Virginia, primarily along the Interstate 81 corridor.
Okay. And exactly what are y'all focused on? What are you doing in this body of work?
Helping to support local community organizations and responses with providing them the latest data trends that we have, as well as news from other parts of the country that we need to be looking out for in our region.
Dr. Reedy just put in the chat that he's still here, that our relationship's not over yet. Okay. I mean, maybe he just doesn't call us frequently. Maybe I travel too much.
Hey, Tony.
Yeah.
Sorry, Mr. Hall or Dr. Hall? I didn't catch in the beginning. But to your point, we are actually working on part of that work group for the Virginia, the Tri-State Corridor. And so what we're working on to kind of flesh it out a little bit for the listeners is we're trying to anticipate when a potent batch is going to come into our area. So what we're trying to do is use data to see, okay, we're setting up a drug checking program as well at our harm reduction agency. And so what we're trying to do is to see where are our drugs coming from. And then if we can determine that they almost 80% come through Baltimore, almost 80% come through Knoxville or whatever, if we can determine that, then if there is a spike and a potent batch going through Baltimore, then we can tell, hey, in 24 hours, there's going to be spikes here. So instead of waiting for the spike to hit us and trying to get the word out to our participants that there's a potent batch there, we can have like an early warning system, almost like with tornadoes, to say, hey, there's a likelihood that there's going to be a potent batch coming through. Get extra test strips, make sure you're not using alone, do some of the work that we are already doing during a spike to try and anticipate it.
Wow. I mean, and so are you putting out like a report? I mean, how is the, I know you got the Jefferson Berkeley Alliance, and there's a ton of folks that I think I know engaged in that, and other alliances over there in the Eastern Panhandle. But how is that information getting out, and what so if it's an early detection, it sounds like an early detection system that you're trying to create, what's the warning? How does the warning go out?
So that's something so this is all very early days. We're still working on the data and trying to figure out how to make this happen. But one of the things, and please jump in, Jim, if you have any other insights, but one of the things that we're specifically working on in our program is with HIDTA. I can't HIDTA, I never say that word right. And then also the CDC Foundation. And the idea is that the alert would go out to our partners. So for example, like us or our health department, and then that knowledge would then be distributed. Currently, our conception is that information would be distributed through our comprehensive harm reduction programs. Throughout Virginia, we have like 15 or 16. So that's the idea, is that either substance use providers, like treatment providers, people that are working with peers, harm reduction agencies, if we can get this model to work, then we can disseminate that information through a partners list that would like kind of sign on to the project.
Mm-hmm. I mean, you as you're explaining it, I'm thinking that it would be, and I think that Raleigh and Lee will probably and Lavina will kill me for what I'm about to say, but I think it would be a really great partnership for us, where we could probably shoot out this information to the folks that are on our listserv, both for the opioid remediation newsletter, but also for the regular CEG newsletter, bam, bam, two methods by which people get this information from you, and we could disseminate it very, very quickly. And I think that, and it's just Mike Kelley already did it. But I think that's kind of, again, that's the reason for this call, right? Is to figure out what folks are doing that we don't know that they're doing, because this sounds like some really great stuff. And Kat, I'm going to put you on the spot and say, I think that is one of those things that if we got to you, you could get out to county health officials with pretty quick, particularly in this region of the country. And I think that that's what we don't have, is that kind of like, how do we get data from the ground up and then get it back out to the individual consumer, but for the organizations who may not be the organization that we think, right? Maybe we're getting it to the winter weatherization people, and maybe we're getting it so that they can say, when somebody's coming in to get their windows taped up, hey, did you know that there's this problem out here that you might want to think about? Because if you're here getting your window taped up, there probably is a primary, secondary, tertiary, or ancillary connection to this issue somehow. So let's make sure everybody in the social, drug sharing, sexual living, familial network has this access to this information.
Yeah, I'll drop my email in the chat for people that want things to go into our newsletter. Well, we have a bunch of different organizational newsletters, and I can always just determine which ones to throw them into depending on what audiences are most relevant.
And so, Stephanie, you're asking about what? You want people to buy what? You want people to buy Narcan? Who needs that?
I'm just, if anybody has, I know abatement's been different everywhere. And because I cover 3 states, I often forget where people are at in the process. But if people do get county level funding that they want to use toward naloxone and specifically Narcan, remember, come to us or come to me directly so I can connect you, because as the manufacturer, we sell direct to public interest places at the lowest possible price with free shipping. So I just want to make sure people, if they have some money that they want to use that way, that they can make sure they're going, because if you go through your state agency, it's not going to be as simple as we can make it direct.
Right. So Jim, is it Dr. Hall or is it Jim? Which is it? Is it doctor?
I have a doctorate from Europe that I don't use in the United States because it's not equivalent to a PhD. So I just go by Jim. Okay, Jim. Jim, we Jim, it's like, again, this is you're the reason that we have these calls. And, is that I think that sometimes we find these diamonds in the rough like you that are out there doing really good work that we want to make sure that other people are aware of. We've put the web address in the chat for the newsletter, but do you want, how should people get involved either in the Jefferson Berkeley Alliance, or if they want to contact you to do a data dump conversation? Because I know Michael's probably going to want to call you about the data that you collected. And I know him well enough to know he's saying that he may say, nah, not really, but he will eventually, because he's a what we call a data. So I'll put my email address in the chat. And also working with the Opiate Response Network out of SAMHSA's Technology Transfer Center. We put on a conference that covered much of these issues, including the overnight alarm and warning system. And we have presentations on that that are already packaged. Can you say a little bit more about the overnight response piece? Well, I'm not as tuned into it as the people that have put that together, but we do have it working in our area and have seen results that cut off overdose deaths and spikes, right, because of early warning. But the people with the Opioid Response Network and also working with the West Virginia Office of Drug Control Policy have more information on that. But I'll get the contacts and send them to anyone who's interested.
Perfect. And what we'll do is we usually send out like just some attachments or links post follow-up to the meeting. And I know that folks from CEG are taking notes and will look up some of these references. But any of them that you have, I would truly appreciate making sure that we can distribute them to the other folks on this call. And I want to thank you for letting me not just pick your brain, but pick on you for a little while here. But most importantly, I want to say thank you for the work that you're doing. And I want to say thank you for the contribution that you've made over time. I think that people don't understand, like this type of work is, I really think is the work on behalf of the people. And whether you've done it in community or you've done it in government, again, I just want to say thank you for your service to us and to the community.
Well, thank you. Thank you for what this wonderful group is doing.
So we are about 10 minutes out. Does anybody have any questions? I don't know where Dr. Lloyd is, so don't make that one of your questions. I don't know. I have a confirmation email. The man said he was going to be here. I don't know what to tell you. But, you know, it is what it is. And I think that we've had a great conversation in spite of, or in lieu of, or in addition to. But we'll try to get him back on. I do know that we have also a confirmation from Francisco Ruiz, who is the new director of the Office on HIV/AIDS at the White House, who's agreed to do a Facebook Live in, I think, next month. So we'll be doing that as a Facebook Live, and I will certainly try to get Dr. Lloyd either back on this meeting or get him on a Facebook Live for us. I'm getting notice that he said we're going to keep people focused. I'm sorry, we're going to keep people posted on rescheduling for Dr. Lloyd. And then they got in here. We know he's a busy man. Well, we know he ain't keeping an appointment, and we know that. But I'll leave that for another day. And 2 p.m. September 4th, we'll be hosting the Facebook Live with Francisco Ruiz, who's been recently appointed as director of the Office on AIDS Policy or HIV/AIDS Policy at the White House. And so that'll be a great conversation with him. Francisco has worked at NASDAQ, I believe, has worked at CDC for a while. And I've known him a long time, and I'm super proud of him being elevated to this position. I think that the other thing that's kind of coming up is that we know that there will be the West Virginia Conference on Economic Development at the Greenbrier. We think that we want to make sure we're there to have conversation about the importance of community health workers and other impacts, particularly the impact substance use disorder is having on the overall economy. And so that we can get folks back to work. We feel like if we can get folks back to work, we can also have an impact on their long-term recovery as well. And I think last but not least, we know the U.S. Conference on AIDS is going to be in New Orleans, and we will be there where we will be talking about the syndemic of HIV/AIDS in the Appalachia region. We were able to provide 30 folks with scholarships to that conference, so we're very proud of that opportunity as well. Last but not least, one of the other things that we did is that we just got back from Munich, Germany, where we participated in the International AIDS Conference, or the International AIDS Symposium is what it's called. And so we presented on that. Kelly, I'm going to put you on the spot for 2 seconds. We did a symposium there called Appalachia to Africa. And one of the things that we really believe that we can do is to provide an opportunity to do some cross-learning. And Kelly, that was your baby. Do you want to talk about it? You got 4 minutes.
Yeah, absolutely. We had an amazing panel. I can't even, I'm still like on cloud nine for how well it went. We had the president and the treasurer of the Society for AIDS in Africa, Dr. Sally Hodder from WVU. We had a community health worker from Mothers to Mothers in Lesotho, and we had Dr. Adzwi from the HIV Vaccine Trials Network, and she's based out of Johannesburg, South Africa, along with Dr. Carl Diefenbach from the NIH on our panel. And the discussion, it really was
moderation credit. Can I get some moderation?
Oh, and of course, Tony was there with all the jokes, and it was great. So the conversation is exactly what it really was. That it was a conversation between people who are leaders in this field, people who work on the ground every day with community health workers, and they see, they see the gaps, they see the needs, and it's really about an exchange between how can we focus on the similarities between Appalachia and the continent of Africa? How can we really take some educational pieces from both places and exchange that knowledge? Because most of us who work in this field know that Africa they're like the pioneers of telemedicine. They're the pioneers of, knocking door to door and getting the health word out to the people. They take volunteers from the community and train them to go out and fight things like Ebola or HIV, or even, like there is an uprising in syphilis. It's not just here in Appalachia, it's all over the world. And they train folks with lived experience, with, MPOX, thank you, Margaret, with lived experience to be these facilitators between the researchers or the health workers and the communities, because like Tony said earlier, those are their social networks. Those are the people that they live, they work with and they love with every single day. They know them the best. And people coming from the outside are not as equipped as the people who live there every single day. And so Tony came up with this amazing exchange idea, and we're calling it the Duality of Rurality Exchange Program. And it's going to focus on exchanging those ideas, that knowledge that we have here in Appalachia and the knowledge that they have in Africa, and providing some cultural insights as well, cultural exposure between the two. So you can, once you've had that cultural exchange, your mind opens up to more possibilities. And that's kind of the goal, is the possibilities. What can we learn from each other, and how can we do things better? Going outside of our, our little bubble of Appalachia and going somewhere else. And the same for the workers in Africa, coming and seeing what we're doing. And we just think the symposium was really a springboard for a really amazing program and a great future. And I have to talk about the hillbilly from Harvard. She's from West Virginia, and she's currently getting her PhD at Harvard. And she was there in Germany, and she came up to the mic and she's like, I just have to tell you, I never in a million years thought that I would come all the way to Munich and hear my people talked about in such a positive light. I never thought I'd hear Appalachia's name anywhere outside of Appalachia. And so that was like, I think, one of those moments where you're like, this is it. This is the right thing. We're doing great things. And I'm going to shamelessly plug our community health workers survey and drop that in the chat. If you have people in your network that do community health work, we would love to hear from them. We really would love to help them, help their thoughts guide this program.
Well, thanks, Kelly. Well, you can say better late than never, but man, that's like 1 minute left. Dr. Stephen Lloyd, everybody.
I am so sorry I'm about to die. I have not got used to the time difference because I'm in the central time zone. And for me, I was a minute early. So I am so sorry, guys. I will get it, though. I'll be moving to the Eastern time zone, so I'll get it. But thanks for having me. And I'm so sorry about the time mix up. I thought it was at 2 o'clock, but it was 2 o'clock Eastern time. So I apologize.
Well, here's what we're gonna do. We are literally 1 minute at the mark. What we're gonna do is that we're gonna ask you if we can rebook this. And maybe what we'll do with this is make it a Facebook Live, if you'd be open to that. And then that way we can get all of these people back, but we'll try to do it in the next couple of weeks. And I know that you're just landing your feet with this new gig as well. But you know, because I know you well enough to know, I appreciate the fact that you showed up here and just to say hello. I told y'all I actually do know him, because you know you got people thinking I don't even know you, that I scammed him.
No.
People thinking I scammed him about your showing up.
She didn't scam you at all, guys, and I'm so sorry. This will happen from time to time. I live in really 2 or 3 time zones, and I just got mixed up. But we will do whatever I can do for you. I'll be in West Virginia starting on August the 26th. And if you need my phone number, there are people on this call that have it right now. Just text me, and I promise you, I care deeply about what you all are doing, and I look forward to being a part of it.
Perfect, brother. I will see you. We will do a Facebook Live soon. Good luck to you.
You bet. Thank y'all.
All right, everybody. Thank you so very much. I think have a great week and keep on doing the work. Jim, thank you so much. Kat, thank you so much for stepping in. Michael, thank you so much for stepping in. I appreciate you. And this is why we do this meeting, because we learn so much about what other people are doing in our region. Thank you, everybody, and we will follow up shortly with a Facebook Live with Dr. Lloyd. Have a good day.